Rita.
Yeah, so inshallah we'll start. Assalamu alaikum wa rahmatullahi wa barakatuh, my respected students. Uh, I think last week or 2 weeks before I took one information. Now they gave me this fracture healing. Basically, I want to teach you the basic wound healing, which is actually very important to understand the fracture healing. Uh, and we should do a very little fast revision, otherwise you will not be able to understand the bone healing. So basically what is happening when there is an injury, I'll just have some few slides empty. When there is an injury, any injury, uh, so what will happen is the body tries to restore the tissues back through resolution or regeneration or repair. So we call this basically, yesterday Dr. Ahmad Badi has taken you, it's called regeneration or repair. Okay, you all people know this very nicely. And when there is a usually a superficial injury here in the regeneration, or there is something like a very severe injury in the repair, uh, so repair will take place, severe injury. Okay, when the superficial injury, regeneration will take place. Now what happens in regeneration is the normal resolution or normal cells come back, or normal function is restored. Here what happens is the formation of fibrous tissue. Yesterday he taught you this one, and I have to tell because of understanding of fracture healing, you need this again. And this is called scar. So here in regeneration, you have a normal function, normal native tissue is restored back. As compared to repair, there is formation of scar tissue due to severe injury, and this is very important to understand. And if you don't understand this, I think fracture will be difficult to understand again. Now, he has taught you yesterday, I think in detail. I'm not going in details. Now, what is happening in this particular wound healing? We have three phases, right? Uh, First phase is called the inflammatory phase. He has already told you yesterday. Inflammatory phase, in which there was a uh, platelet clot formation. Clot formation was there, very important. And finally, the fibrin clot. Plus, there was inflammation or inflammatory cells like neutrophils, lymphocytes, macrophages, monocytes. They will all coming over. This was the first phase in the healing. The second phase was called the proliferative phase. The proliferative phase. This also he taught you very nicely. And this very important consists of epithelialization. Epithelialization. And number B is called fibroplasia, and number C is angiogenesis. Angiogenesis. Now this is called granulation tissue, and this was very important yesterday when Dr. Ahmad Badi was teaching. And this is the main tissue, granulation tissue. So what I used to teach in India was I used to call this immature fibrovascular tissue. Immature, not mature. Okay, immature fibrovascular tissue, Usama granulation tissue. Now you should know this is the second proliferative phase. First phase, inflammatory phase, Usama platelet, clot, and fibrin inflammation. Then this is the one. Third phase was very easy, of course, to remember, the maturation phase. Okay, this is called scar formation. Okay, the scar formation which we have drilled just now. The scar will come in the repair mechanism. Regeneration will have the normal cells. Now, if you are understanding this, is very important. I'm not going to go into detail of the primary intention and secondary intention. Basically, primary union is due to what's very important to understand. Just to have that very uninfected, very clean wound you have is called primary union, and secondary union is very unclean wound, infected wound. Then you have lot of problem. When in the primary union we have very small scanty granulation tissue, whereas in the secondary union, when the wound is not clean, we have a exuberant or excess granulation tissue. So please remember this terms called what do you call it, granulation tissue. primary union, secondary union, and these three phases and regeneration and repair. And with this particular thing in background, I want you to understand certain things of the bone now. We are going to the bone, what do you call it? Bone or fracture healing, right? We call it bone remodeling. I did not start my slides till now. I want you to understand. And Mohim Jiddan, you people should buy the basic Robbins from Jareer 11th edition. Please, please, okay? Because now I'm teaching the third year also. I force them to buy it and read it and ask me questions. Or you can come in a group, 4 or 5 people, 2, 3 people, put the question like in the morning, one of your friend has put 6 or 7 questions. I will answer her. No problem. Like this, okay? So bone remodeling, what is happening when there is an old bone or a brittle bone, okay? Or a small, cracks are there in the bone, like you're doing exercises, or you have a fracture. I put the fracture like this in the hospital. Now, these are all these things are resorbed. Remember this term called resorbed. That is, these bones have been taken up and replaced by new bone formation. Okay, or new bone formation. So all these things, micro cracks and brittle bone and fractures, all this has to be removed, resorbed, and replaced by new bone formation. So actually, you people already know it that suppose this is a bone like that, and the outer structure is called Usama periosteum. Okay, periosteum, very important. Periosteum has 2 layers. Okay, the outer layer Usama fibrous layer, and the inner layer Usama cellular layer. Now it's very, very important. Okay, the cellular layer contains progenitor cells, or you can call it osteoprogenitor cells. هذا زي آباء وأجداد, في الشجرة, the progenitor cells like يعني. From where we form what cells? We form the osteoblasts, and we have chondroblasts. Remember these points, they are very important. Okay. Now osteoblasts form the bone matrix, the main bone, they form the bone matrix, and chondroblasts form the cartilage. Now, if you remember this particular things will be very easy for you. Okay. Now I'll try to tell you one more thing. Now, what is happening? For example, you take the femur bone like that, the upper part. So this part is little thicker, and this part is little thicker. يعني هذا العظام قوي شوية. هذا يسمى cortical bone. شوف هذا قوي شوية. هذا هنا شوية مو قوي. هذا يسمى spongy bone. Okay, spongy bone. I hope you're understanding. Can you hear me, Rami? I think I'm audible. Hello?
Yes, doctor, we can hear you.
Okay. Now this is the cortical bone, Gavishoya, spongy bone, Juba. Okay. Now you got to know this, and you already know that this is called epiphysis, this is called metaphysis, and the shaft is called diaphysis. And you should know all such things. So cortical bone is basically made up of thick collagen. Okay. Collagen, we already know it because you people have read yesterday with Dr. Ahmad Badi, the wound healing, so you know about the collagen, and it is also made up of calcium plus phosphate. Okay. Now, any person who has a brittle bone or a bone losing, you try to give all such things. So in this, we have Haversian canals like that. In the Haversian canals, we have blood vessels, and inside the main thing is called the medulla. In the medulla, you have the bone marrow, al-muhim jiddan, bone marrow. Bone marrow has a shirka, is a factory which forms the hemopoietic stem cells. Okay, the hemopoietic stem cells have lymphoid stem cells and the myeloid stem cells. Lymphoid stem cells, they form the B and T lymphocytes, they are called helping in the adaptive immunity, and the myeloid stem cells, they form all those neutrophils and all such things, RBCs, all such things. So this is very important. So all these things. So if you not forgetting this periosteum, the outer layer fibrous, the cellular layer, the inner layer which has osteoprogenital cells which make the osteoblast, bone matrix, and chondroblast, the cartilage. Now this is very important. Okay. Now one more thing I just want to tell you, which is not there in your PowerPoint. I just want to tell you these osteoblasts. Remember, osteoblasts, which are the bone forming cells or bone matrix forming cells. Okay, remember, okay. Now they secrete a substance called, you can go to the Google and search, called rankle. Okay, this is a activator, of the cell activator, which activates to form the monocytes, to activate the form the osteoclasts. Osteoclasts. Now these osteoclasts are bone resorbing cells, removing, okay, resorbing cells. The bone forming cells are bone matrix, and osteoclasts are bone resorbing cells. Okay, these contain two things very nicely. You should remember collagenase. Now, people, if you go and read Robbins, it will be very easy. I'm telling from Robbins only. Collagenase and the hydrochloric acid. Okay, now hydrochloric acid will take out the calcium and the phosphate, and the collagenase will digest the collagen, because you are resorbing the bone. When there is old cracks, okay, you do exercise in Nadi or Hakada, you've got to remove and replace it by the bone forming cells. So these are the osteoclasts. They're actually basically formed from the rankle, which are the activators, ligand activators or reactivators, activators, which will form this thing. So these are all the things which are present in your textbooks. So if you just though this is what I want to tell you, that the rankle will activate the monocytes. So this is actually destruction of the tissue for replacement of normal bone matrix. Now, if this becomes more activated, osteoclast, so whole bone will be removed. So there should be a control. So again, a control. Again, I go back to osteoblasts. Okay, they have one more cell called, remember, osteo protegerin. Osteoprotein. So this also binds to rankle. Again, rankle. If you bind to rankle, now this will deactivate the osteoclasts, which were the bone removing cells or bone resorbing cells. It will deactivate. So this osteoprotegerin will deactivate by binding to rankle the osteoclast, such that it controls. So now osteoclasts will go for a suicide by the mechanism called apoptosis. They should be removed over and over again by the feedback mechanism. Now the osteoblast again will secrete osteoid steam. Okay. Now this will form will go and form the lacunae. The lacunae are filled with the calcium and phosphate. Okay. Now this is the one. And these osteoblasts again will be trapped, and they form the bone forming cells, Yusamma osteocytes, the cells which form the bone. Okay. Now there's a turnover of this one. So osteoblasts have three functions. One function is to through the rankle to make the osteoclast for bone resorbing, and through osteoprotegerin protects the bone matrix through deactivating osteoclasts and secreting osteoid steam for calcium and phosphate deposition, and they turn into osteocytes. They are the bone forming cells. Now, if you remember this one, it will be very easy. Now, there's a hormone called, very important to remember, such that you people will not be confused. Parathyroid hormone. Okay, when the calcium is decreased, now this hormone is increased, and it will activate the osteoblasts through the rankle and for bone resorption. So bone resorption. Then when the bone resorption takes place, the calcium will increase. So this will activate the osteoblast and will activate the rankle for bone resorption. Then when the calcium was low, this was released, and then again when the bone is resorbed, the calcium will be increased. So this is very important. Number two is parafollicular cells of the thyroid. Parafollicular cells of the thyroid, they secrete calcitonin. Remember, calcitonin. Remember, okay. Now, when I give this lecture, your work is to go and read Robbins. Please the things will become very easy. Okay. Now, when there's increase in calcitonin, the bone resorption will decrease. Bone resorption will decrease. Resorption will decrease. Okay. So number 3, nowadays people are eating a lot of vitamin D. The vitamin D will have increased intestinal absorption of calcium. So these are the 3 different areas where the bone we help in bone remodeling. Bone remodeling, very very important to understand, or fracture healing. So so in conclusion, bones are resorbed by osteoclasts. Remember, osteoclasts. Bones are remade, by osteoblasts. Okay, remember, okay, through the rankle, you know it, or the rankle. Okay, so this helps in remodeling or healing, very very important. So now this osteoblast also secrete osteoprogenitor, as I told you, that is helping in turning of the remodeling. Now this is the thing. We'll start our lecture now, and the things will be easy for you now. Okay. Now at the end of this lecture, I just decreased the slide. There are 53 slides. I made it 44 or 43 just to made it more easy. At the end of this lecture, you should discuss and explain definition of healing of bone fracture, not healing of the skin wound, not that one. Okay, not the skin wound, but the healing of bone fracture. Okay, explain the mechanism and stages of fracture healing process, and also describe the factors affecting the healing. Now, this is very important. Please don't think of exams. Try to understand the disease process. Okay. Number 4 is to show the possible complications of the healing process. Haza hua. Now, fracture healing, as I told you, the basic process resembles the wound healing which Dr. Ahmad Badi taught you yesterday. I also did a very small revision. The primary union of fracture never occurs. Now, this is again a very important point as an MCQ in the examination. Okay. Now, healing occurs by production of callus. Now, our main focus today is what is callus. I will teach you. Don't worry. Okay. What is callus? Now, healing is of the bone is produced by formation of callus. Unlike skin wound, which Dr. Ahmad will teach you, healing here occurs by production of bone forming tissue, not scar. So there is no scar, remember, and instead there is formation of callus, and it will cause the production of bone, that is formation of bone matrix, that is through the osteoblast. I hope you understand. I'm going a little slower, but I want to finish it before one hour. So now, what is introduction? Fracture is a break. You know that the fracture is a break in the bone. You already know it. Break in the structural continuity of bone, or even the periosteum gets cracked up. That is also called fracture. The healing of a fracture is in many ways similar to the healing of a soft tissue, what people have studied yesterday. Almost similar, but terms are different, except that the end result was there it was scar. In the wound healing, here it is mineralized, that is calcium plus phosphate mesenchymal tissue called bone. You some Mahesh? Bone. Fracture healing starts as soon as bone breaks, and as immediately it starts and continues modeling. We call it remodeling. Okay, remodeling for many years, but it becomes stronger and stronger and stronger over a period of time. As a introduction, fracture healing. Now, the type of fractures, this is not for the examination, just to Hada Usama hairline fracture. Inshallah, now you are in second year and you go to third year next year, we'll meet again. Then you go to fourth, fifth, sixth year in Malik Fahad Hakada, you'll be seeing these fractures from morning to evening. Hada Usama hairline fracture. Zai hair yani. This is called oblique, displaced fracture. This is also oblique, non-displaced. Displaced. This is not displaced. This is intact, but this is an oblique fracture. Here a linear fracture. Here is a comminuted fracture. Something the bony fragments are clearly visible. This is a spiral fracture. It's something turned off like that. This is a segmental fracture. This is only for your knowledge sake. That's all. Okay. Now, component of bone is very important for understanding the bone healing or bone fracture healing or bone remodeling. Now, you should know This is the skin, right? This is the skin. Okay, this is the skin. Okay, and you go to the skin. This is the subcutaneous tissue. Okay, this is the subcutaneous tissue. Okay, then you have this muscle. Okay, this reddish thing is the muscle. Okay, then you have a bone inside. Shufina, bone. As a shay barra yusama periosteum. Okay, barra yusama. So the outer layer is very fibrous. Inner is cellular layer, which contains what? I go back because I don't want to you to forget it. Now this is very important. Okay, see, the outer layer is some fibrous, the inner layer is some cellular. This contains the bone cells, osteoprogenitor cells like osteoblasts and chondroblasts. Okay, okay. I just go back to the diagram. Now this is very important. Okay, now this is the periosteum which contains the osteoprogenitor cells, that is cells, osteoblasts and chondroblasts. Okay, after the periosteum, there's the cortical bone. Shuf, cortical bone. As I show a gavi. Okay. And after that, if it is in the upper part of the femur, we have a cancellous bone also. But inside Juba, this is the medulla. And this contains the bone marrow, which is the factory, has a shirka for formation of all hemopoietic cells of the body. Okay, this is the basic thing. So we should know what is cortex, and we should know what is periosteum. We should know what is bone marrow, and we should know what is soft tissue, is a hina muscle. Okay, I hope you understand. Now, factors affecting the fracture healing, or to get back the normal bone when there is a crack. So the type of factors, the amount of thing which is involved, the location of the bone which is formed. So fracture type. Now I showed you the different type of fractures. If the fracture muscle is like this, commuted one, which have small, it will take a lot of time. If the fracture is hairline, oh, mashallah, very easily. The fracture type. Is the gap condition okay or not? I go back. Shuf. Is the gap condition is not good, the fracture healing will take longer time. Now this is good, and this is good. Okay, this will heal quickly. Okay, a fracture type. Then the fixation rigidity. Are the bone fragments fixed properly, or there is malunion? All these factors will affect the bone healing. Okay, inshallah, we'll read this, and a lot of MCQs will come in the examination. Fixation rigidity. If you go to a proper orthopedic surgeon, he will fix properly. If you go to a quack, he will not fix properly. And the loading. Suppose you have a loading area, for example, you have a tibia and a femur where there's, always your body is loaded on it. So healing will be a little slower. That's why the doctor says stay at home and lift your leg like that for 7 days, like that, such that loading decreases like that. And the biological environment in which you are living. All these are the factors which helps in or affect the bone healing or bone fracture healing. Okay. Now, fracture healing types. You should know it. For example, fracture healing type is divided according to the bone. You know that when there is a bone is gavi jiddan, yani yusama cortical bone of the shaft. Okay. Now you can see over here how the cortical bone. Shuf, the cortical bone. Shuf. وهذا مو قوي هذا يسمى cancellous bone. Okay, now this is the cortical bone looks like this. You can just when I stop the lecture, you can make this zoom out. Compact bone, we have a Haversian canal system, the osteon. This contains blood vessels. Shuf has a sagir, has the osteocytes which are formed from osteoblasts. You already know it, mashallah. And the cancellous bone, which is Laisa Gavi, have all this. Usually, now this is again an MCQ. Cancellous bone is present in the metaphyseal region. Now I can tell you this one. Now this area is the metaphysis. This is the diaphysis. Okay, this is the epiphysis. Usually this area contains the cancellous bone of the long bones and the small bones. So if you go to the histology, you can see a lot of trabeculae in the cancellous bone. Okay, so this is basically the outer part is the compact bone. Here, this is the little inside is the spongy or cancellous bone. Now you should remember this is very easy to remember. Now stages of fracture healing. Now I told you what is important in healing is the formation of callus, right? Now callus is very important to understand. Now what is callus and what we are supposed to understand with the callus is all such things which are very important. Okay, otherwise we don't understand. Now actually starting what is the callus? The soft callus is a type of soft bone. So now I've taken this exactly from the Wikipedia internet. It's a very good definition. Soft callus is a type of soft bone. Replace the blood clot. شوف هنا أول كان في blood clot formation. See here, hematoma is a blood clot formation formed in the inflammatory stage. Now, with the hematoma and the inflammatory, you remember yesterday wound healing? I just told you just now when I was revising that wound healing, I was telling you that in the steps of bone repair, the first step was the inflammatory phase in which there was clot formation and inflammation. Here also see the hematoma will form a clot, then inflammation. So he says the soft callus replaces the blood clot that formed in the inflammatory stage. The callus holds the bone together. Now this is the area where the callus holds the bone together, but it's not strong. It's a very soft one, enough for the body part to be used over the next few weeks. The soft callus becomes harder callus over a period of time. So soft callus will become after some time hard callus. Now that is why you see the people with the fracture, they are in the either they hang of the in a sling, their hands, or if there is a leg one, they will be having crutches just for the thing to heal up. So the first was tissue destruction with the clot formation or hematoma formation. Then as yesterday, inflammation and cellular proliferation. I'll show you. Then this is the main thing, stage of callus formation. Then this callus, soft callus, slowly will become consolidated, and it becomes solidified or hard. Yusamma consolidation. Then stage of remodeling. Now this is the most important slide which I want to tell you, and I think you people are understanding. Now tissue destruction and hematoma formation. Now in the starting what is happening, all these vessels are torn up. كسر الوريد الشريان في هنا وفي طبعا يعني في hemorrhage will occur. A mass of clot or a hematoma is formed over here. You can see at the fracture site. As I told you yesterday, that in the starting part I told you inflammation will occur. Then of course the clot formation is there. Here also the same thing. This particular site becomes shoya, kampara shoya. You some are swollen, painful and inflamed. So this becomes swollen. Now this is the tissue destruction, as I told you, the first phase, which is very important. Now we go, now this is the diagram, tissue destruction and hematoma formation. You can see the torn periosteum. Hada hua periosteum which is torn, and you can see all this hematoma formation inside. This is the dead bone over here. Now this has to be approximated for healing. Now what is the importance of a orthopedic surgeon? He puts this together and try to put a plaster over it. This is the intact periosteum which is living. Dead bone is usually doesn't heal properly. Now this is the area of the necrotic bone. So you got to remove this and try to see that the living bone should go and approximate each other. Okay. Now after that, the second phase I told you is inflammation and cellular proliferation. The cells will proliferate slowly. The cells of the inflammation, like macrophages and all such things, what will happen? Slowly, is got to know it. The fibrocartilaginous of the soft callus formation occurs. Osteoblasts will come and fibroblasts migrate to the fracture site. Okay. And beginning reconstructing the bone. Fibroblasts secrete a lot of collagen fibers that connect the broken bones. Osteoblasts begin forming starting with the spongy bone. Osteoblasts further form capillaries secreting externally bulging cartilaginous matrix. I told you chondroblasts will come, osteoblasts will come. Then they later slowly they will start calcifying. So within 8 hours of the inflammatory reaction, proliferation and differentiation of the mesenchymal stem cell, that is the progenitor cells will activate, and this will secrete the TGF, beta and PTGF, and BNP factors are there. You want to know the BNP factors, write down on the Google BNP factors for bone. Then you get more knowledge through the Google. So these are the factors, growth factors, which help in cellular proliferation of the bone to get what? To call for the osteoblasts and chondroblasts such that new bone is formed. Now this is the stage. I'm going back. Tissue destruction, hematoma, inflammation, and cellular repair. Okay, we go furthermore. Now this degranulated platelets and migrating inflammatory cells release platelet growth factor, transforming growth factor beta, and fibroblast growth factor, and other cytokines such which activates the progenitor cells, that is the osteoblast and chondroblast, in the periosteum, that is the cellular layer of the periosteum, which I already teach you, the medullary cavity, that is the bone marrow area, and the surrounding soft tissue to stimulate and produce what? Osteoclastic as well as osteoblastic activity plus chondroblasts. Okay. Now these three things will help in the bone formation. Osteoclast will remove that bone, osteoblastic will form the bone matrix, and chondroblast will help in formation of membranous ossification. Okay. Thus, by the end of the first week, the hematoma is organized. That clot is organized. Adjacent soft tissue is being modulated for future matrix formation, and now you have a soft callus formation. Okay. I go further more now. I hope you're understanding. Now, this is the main area of understanding of callus formation. What is this callus formation? Fibrocartilaginous callus forms. You should know that internal callus, it contains fibrous tissue, and of course from the chondroblast, the cartilage tissue. As yesterday you read from Dr. Ahmad Bali, today also I told you granulation tissue is a soft callus. Remember, granulation tissue is a soft callus. Please don't forget. And what is granulation tissue? I told you in my terminology today, immature. What was that? Immature fibro plus vascular tissue. It is very, very soft, and it helps in the healing both in the skin, soft tissue as well as the bone. So this is actually the callus formation. In otherwise, it is known as granulation tissue or soft callus, which forms a few days after the fracture. Now, what is happening in granulation tissue? It is vascular also, right? Vascular also. So there will be capillaries grow into the tissue, and phagocytic cells begin to clean the debris. All the cells of monocytes and macrophages will come and try to clean it. I go back again, such that you should know it. First was tissue destruction, hematoma formation. Second was inflammation and cellular proliferation. Third was stage of callus formation, and you already know mana callus. Okay, I go furthermore. Okay, now this is a diagram. You don't have to remember. This is very easy. Organized hematoma, cartilage and bone. Cartilage is formed in early newborn formation with the help of bone resorption, osteoclast, and bone formation, osteoblast. And we have a soft callus, usama granulation tissue. The fourth stage, that is consolidation. That soft callus will become solidifies, okay? And the usama consolidation. New bony trabeculae appear in the fibrocartilaginous callus. Now, this is very important to understand. You know, if you don't understand this, this becomes a little difficult. So this, I told you the soft callus, which called the fibroblast, the phagocytes, all those fibrocartilaginous callus, osteoblast came, and the collagen has been laid down. Chondroblast made the membranous ossification. Now what is happening is, now this consolidation is formation of the what? Bony callus. That was soft callus. Now this formation of bony callus. I hope you understand. Now this bony callus begins after the fibrocartilaginous callus converts into bony hard callus, begins 3 to 4 weeks. Now they will ask you in the examination, MCQ, after injury, and continues until the firm union is formed in 2 to 3 months. So this is the main thing of the formation of the bony callus. Now this is very important. Now the remaining cells which are remaining there has to be removed. Osteoblasts also come and try to give more bone matrix, and osteoclast will remove the debris and all such things. Now this is very important. Now this was stage of consolidation. I go back such that you remember. Now this, our main teaching is this slide only. Tissue destruction and hematoma formation, inflammation, cellular proliferation, stage of callus formation, what the soft callus, stage of consolidation, hard callus. I hope you understood nicely. Now this is the last stage called stage of remodeling. Okay. Now stage of remodeling. What is happening in remodeling? You got to know it. Excess material on the bone shaft exterior and in the medullary canal is removed. All the excess material is slowly removed off such that the remodeling occurs. You know, all these people who are models who want to show their faces very nicely, they try to remove all those things which are on the face and try to make it, you know, perfect like that. So although all those excess material is removed and all the bone is actually remodeled, and that compact bone is laid down to reconstruct the shaft walls. All the shaft walls become normal. So this is the basic structure of our teaching today. That is the first stage: tissue destruction, hematoma formation, inflammation and cellular proliferation, stage of soft callus formation, stage of hard callus formation, consolidation, and remodeling. So this is the area we should understand. I think that is all we are supposed to know. Okay, now this is actually diagrammatic representation which you people and it's very easy for you. This is a schematic representation drawing the callus healing formation. Now first is the early, you can see early intramembranous bone formation. So in this you get the osteoblasts and chondroblasts which help in intramembranous bone formation. Then you can see the growing callus volume. There is a soft callus and diameter then formed with the help of the chondroblast to form enchondral ossification. Okay, this is actually the soft callus. Now here, what is having this particular area tries to conjoin, it's called bridging of the fragments. Now this is basically like that. It's very, very simple. The external callus and the periosteal callus, such that it's only a schematic representation. Now what are the variables? What are the factors which help in the fracture healing? Now this is very important. Now these factors you got to remember, because once you go to the hospital in the mustashfa, the doctors will ask you, the consultant, oh doctor, can you just see that patient, that particular area is not healed. Just ask him to take the history. You find that this patient might be suffering from hypertension or diabetes, or he might be having some disease, metabolic disease, or he might be having some bone disease before, or they might be having osteoporosis, or they might be, you know, the union is not proper, like that. So there are a number of variables which will affect the fracture healing. Now, number one, you should know open fractures. When the fracture becomes open, the bone is, you can see the bone from outside in accidents. So this will help in impending or preventing formation of bone. So this is formation of hematoma. So if the fracture is open, the hematoma is not formed properly. So delayed formation, repair tissue occurs because of the open fractures. Okay, and the risk of infection is very high. So open fractures, the healing is slow, because it is risk of infection and delay in the repair formation because it is open, and proper hematoma formation, clot formation is not there. Okay, now we have injury variable intra-articular fractures. When the fracture is in the rukba is a cartilage, articular cartilage. Okay, when they get attached to that particular conjoint. Okay, if the alignment and the congruity joint surface is not restored, if at the point this particular area is not conjoined properly, then the healing will be slow again. Okay, it's called intra-articular fractures. Healing is slow because this delayed healing, and it will cause non-union. They'll be like this. Union will not be there properly. Okay, and because the rukba is become stiff, the joint of the knee or the elbow becomes stiff. Now, usually this one. So it's in the intra-articular fractures like segmental fractures and the soft tissue coming in between. Now, this is the joint. The soft tissue is encroaching, interposition. So healing will be slow. Okay, and damage to the blood supply. That is, this blood supply will not cause proper hematoma formation or clot formation. When there's hematoma formation, other blood vessels will call the inflammatory cells. So damage to the blood supply, all these will cause decrease in the healing of the fracture. Okay, we have hormones. Very important to remember. They ask in the examination, corticosteroids and growth hormone and thyroid hormone will, if it is there, will cause little decrease in the healing of the fracture. Calcitonin and insulin and anabolic steroid will cause increased rate of fracture healing. Whereas in diabetes, as I told you, and hypervitaminosis D will cause decrease in fracture healing. So fracture healing will decrease, where they will ask you this question usually when there's diabetes, when there's hypervitaminosis and rickets, all this will decrease the fracture. Fracture healing is fast in calcitonin, insulin, and anabolic steroids. And even if you give lot of corticosteroids and growth hormones, all this will also decrease. Now, nicotine, if you smoke more, all these things will inhibit the fracture healing. Also, this was asked before in the examination. This will hamper the formation of new blood vessels, that is vascularization. So how the hormones are affecting the healing is again very, very important to remember. I think these things are very easy for you, because the most important thing today was, I told you, is the pattern of the fracture healing. the steps of fracture healing, which we have finished. Now, tissue variables. Are we dealing with the cancellous bones, Mo Gavi? Are we dealing with the cortical bones, Gavi Jiddan, Marra Gavi? Are we dealing with the bone necrosis? The fracture healing is slow. When there is infection, the fracture healing is again slow. Okay, this is very, very important. Now, all these diseases, like I told you, the patient with osteoporosis, osteomalacia, primary malignant bone tumors, metastatic bone tumors, fibrous dysplasia, benign bone tumors, bone cysts, osteogenesis imperfecta, Paget's disease, hyperparathyroidism, these will hamper or decrease the fracture healing process. Remember, okay? Very important. Now, treatment variables, again, we are increasing when there is apposition of fracture fragments. The opposition is not proper, as I told you. It should be properly aligned, right? Like that. So, when there is a lot of load on the leg or on the arm, or there's a small micro motion, the fracture healing will be affected. Now, loading of a fracture site stimulates bone formation. When you actually try to approximate this area and try to load close together, there will be increase in the fracture healing. And slight micro motion promotes fracture healing. Now, this is very important too. Loading a fracture site stimulates. If you approximate these sites, try to load this particular area, the fracture healing will be fast. And when there is small micro motion, the fracture healing will be fast. So you got to oppose the fracture fragments properly. That is the skill of an orthopedic surgeon. Okay. Now, what are the complications of fracture healing? There is a union, but the union is malunion. Okay. There's a delayed union. Union occurs, but it is more time. Why more time? We got to know it. This is the complication. When there is non-union, the bone fragment will be like that only. So you should know ma mana malunion, ma mana delayed union, ma mana non-union. Okay, we'll see some slides. I removed many slides such that it will cause confusion to you. So malunion is the malunited fracture in one that has healed with fragments in a non-anatomical position. So when the anatomical position, suppose this is the anatomical position, this was the one, this was the bone here. Now, if the anatomical position has been disturbed like that, it's called malunion. Okay, you can see some people in the haram. If we go like that, after the surgery, their union is not that. So the hand is something in a improper position, leg in a improper position. Malunion. What are the different causes? They might ask you this one. Inaccurate reduction, because the technique done by the doctor or the orthopedic surgeon is not good, or ineffective immobilization. Yani you have to immobilize by the sling process or the crutches. If you don't immobilize properly, then there's a malunion. Malunion can impair the function by abnormal joint surfaces. The joint surface will be abnormal. There'll be rotation or angulation. As I told you, it will become angulated like that. Okay, or overriding. Sometimes what happens? The bone will override on the other bone like that. Movement of neighboring joint may be blocked, so that the neighboring joint is already blocked. So this will cause malunion. These are different causes of. It's very easy actually. Delayed union. Why there is delayed union? The exact time when given a fracture should be united cannot be defined. We cannot define, but actually we can have a tentative time that this particular fracture can take 2 weeks or can take 2 months or 2.5 months. Union is delayed when healing has not advanced at the average rate for the location and type of fracture. That is between 3 to 6 months. Usually all the bones should be able to heal up. Now this is very important to understand. Treatment usually is by efficient cast. You know, you put the cast, where you can see the people who are stringing their arms, stringing their body parts in a cast is very important, such that it allows much function as possible can be continued for 4 to 12 additional weeks, such that efficient cast should be there. So treatment usually is by an efficient cast that allows as much function as possible can be continued for 4 to 12 weeks, such that there is no delayed union. If the cast is not put properly, there will be a delayed union. Non-union. So the FDA, the committee of the FDA defined non-union established when the minimum of 9 months has elapsed. Now this is an MCQ. Has elapsed since fracture, no visible progressive signs of healing for 3 months. So 3 months, no healing signs. up to 9 months. This is called non-union. Every fracture has its own timetable. That is long bone shaft fracture 6 months, femoral neck 3 months. Now remember, femoral neck, they asked before, is 3 months, please. And the long shaft bones, like the femur or the tibia, is 6 months. Now they asked before this one. That's why I'm telling you. Now non-union. This is the different non-union. You can see number 8. This is called a torsion wedge non-union. This is called commuted. Commuted non-union, and this is the defective motion, the defective non-union, and this is the atrophic non-union. Now this is very, very important to remember. And it just, if you remember the names, that is enough. So vascular, or this is the torsion wedge. The torsion wedge intermediate fragment is that. This is the committed necrotic fragment. You can see over here, intermediate fragment. This is a defective loss of fragment of diathesis, and this you can see very clearly. There's an atrophy over here, atrophic scar tissue. No estrogenic potential is replacing the missing fragment. Maybe this will occur in a female who has already undergone menopause, so they try to supplement the estrogen such that this atrophy doesn't occur. So non-union is continued. Where apart from this, you have an infection, so the healing will be decreased, or non-union will increase. Poor tissue quality is there, osteoporotic tissue, or short peri-articular fragment, small fragments coming up, non-union occurs, and significant deformity is there, already there, so non-union will occur. Now this is very easy to understand. It's very logical. You don't have to think much. All logical. If you want to really know all this non-union, malunion, you can see some little videos in the YouTube, and all these people, the big orthopedic surgeons, made some videos which is actually very useful for you all. Okay, and what are the factors which are actually delaying and non-union factors? Is number 1, children. Remember, children heal more quickly than adults. So children have a good healing than adults. Healing potential decreases with advancing age, and the age increases more than 55, 60, like that. Healing will decrease, and when the age becomes 75 and 80, decreases more. Okay, remember. Okay. Now, when the nutrition is there, poor nutrition and vitamin deficiency adversely affect healing. Nowadays, people eat. They come to our clinic that they want to take vitamin C, vitamin D. That this causes proper healing, of course. Okay. Now, general health, chronic illness despite healing process like diabetes, al-muhim jiddan. Oh, come on, anemia. Anemia will have little RBC and all the structures, so less oxygen will come to that area, and the healing will be decreased. And of course, when the systemic iltihab in the body, like we have for example, the whole of the body is affected. There's high fever. All such things will cause a malunion, delayed union. Okay. Now, local factors: when there is an open fracture, healing is decreased. When there's infection of the fracture, healing is decreased. When there's impaired blood supply, healing is decreased. When the fracture is committed, small bone fragments, healing is decreased. Insecurely fixed by the surgeon, or immobilized properly by the technician, or for an insufficient time by the doctor, healing is decreased. Okay. Treated by ill-advised open reduction. They did the operation, Savi Amalia, but the open reduction was not properly, so healing is totally decreased. Okay. Now, distraction of the traction plate and screws are distracted after the surgery. Suppose there's a surgery, and you take the X-ray. Okay, the screw there's the screw here, the screw here. Now, after some time, if you see the screw is actually displaced outside, something outside, or this is distracted or displaced, traction plate and screws will cause decrease in healing. Irradiated bone. If you give lot of ASHA, for example, a patient who has have a cancer and they're undergoing radiation oncology treatment, giving lot of radiation, that will have a decrease in healing. So delayed weight bearing more than six weeks will also decrease in the healing process. Soft tissue injury. If the injury, suppose this is the fragment and this is the fragment, and the soft tissue is coming in between. Okay. Method of initial treatment. So you got to remove this soft tissue, try to approximate these bone fragments. Try to approximate the bone fragments, remove the soft tissue, then the healing will be fast. So soft tissue injury, method of initial treatment has to be removed such that fracture, local factors occurs. Now this is actually the one, it's a revision slide. You can remove this. This doesn't have any importance. All these things you already know. I told you about the spongy bone, the cortical bone, the periosteum, the compact bone, everything you know it. This is only the old slides are there. Had doesn't. So this is only for this one. So this is the revision which I am telling you. Now these are additional slides. Your lecture has finished. Now just for the revision, number 1, hematoma formation. Number 2, inflammatory reaction. You already know it. Soft callus formation, that is granulation tissue. Already know it. Fibrocartilage is formed. Then the osteoblast laid down osteoid. I told you. Later calcified, that is formation of a hard callus, formed of a woven bone. Then, of course, the last is the bone remodeling, that the osteoclast remove the unwanted callus and woven bones become lamited and become very strong. The Kullu revision. Okay. Now, the immature bone and mature bone, you should know. This is the woven bone on the right hand side. This is the non-laminar bone on the left side is the immature bone. Woven bone is uniform bone. Collagen fibers are still disorganized. Okay. Woven bone is remodeled into a lamited bone. Remember, lamited bone is the bone which forms the very strong bone. The striking feature of bone healing. Now, this is always an MCQ in the examination. The last point you can see the striking feature of bone healing compared to the healing of yesterday, which Dr. Ahmad Bari teach you, is that the repair is by original tissue, not scar. There is no scar in bone fracture healing. Hada very important point. I hope you are understanding, right? 3 phases involved in healing fracture. The Kullu revision. Immediately after fracture, rupture of blood vessels take place. The Kullu revision. Blood clot. And Tarif Kullu Shay. And Tarif hematoma. And Tarif inflammatory cells. They come up and activate the osteoprogenitor cells and forming the periosteum and the medullary cavity. And Tarif Kullu Shay. I already told you. The hematoma is called a procallus, not a callus. All these things are there. Okay. So reparative, you know it, the osteoprogenitor cells, they are the cells deposit the woven bone and both at the periphery and the medullary canal, and this woven bone, and finally they over a period of time they form the lamited bone, which is very strong bone. Okay. Now we go furthermore. The activated mesenchymal cells in the soft tissue surround the fracture, differentiate into, I told you, chondroblast deposition cartilage, that is at the point of soft callus. Okay. The mixture of new cartilage, granulation tissue, that is a soft callus is called, and woven bone is called a callus, which I called is soft callus for you, right? Soft callus. Very easy. All revision, remodeling occurs. The cartilage in the callus undergoes endochondral ossification through the formation of chondroblasts. Chondroblasts. Okay. All this thing, you know it. The new bone formation undergoes remodeling to form the strong lamellar bone. The region of fracture with remaining disrupted trabecular at the left and bottom. Paler pink new bone is formation at the right and top. Paler pink new bone at the right and top. See, sorry. Right and top, this is the new bone. Okay, this is the new bone formation. Okay, go back. Region of fracture with remaining disrupted trabecular at the left bottom. Still, this is still in the healing process. And the new bone formation is over here. You can see new bone formation over here. There's still the fractured bone over there, still trying to get repaired. Now, there's only histology just to show you what is actually happening. Now, this is another diagram. In this region's recent fracture, callus forming at the broken end of the bony trabeculae and that extend to the center from the left top. So, you can see the left and top area, new callus formation is very clearly seen over here. You can see over here. Now, this is very, very clearly. And this area will become the bony callus. So, this is just to show you the diagram. We are pathologists, basically. So, this is not very important for your examination, but to remember that, you know, what is actually happening. Now, the last slide is an irregular new bone or woven bone which is forming in the region of the fracture. Okay, new bone or new woven bone. Osteoblasts are seen lining the irregular trabecular, and there is an osteoclast near the center. Now, this is the osteoclast in the center, and these are the osteoblasts which are forming the new bone formation. You can see over here. Now, this is just to show you the diagram, actually what is happening. Now, the small cells are the osteocytes, which are formed from the osteoblasts, and the osteoclasts are little larger, giant looking cells, which are very important, you know, are seen lining the inner trabeculae, and there is an osteoclast near the center. Now, this is actually what the thing I hope that you people understand, and inshallah, things will become more clear. Are there any questions? Shall I take up? That the time is finished. Anyway, 15 minutes are there or 14 minutes. I hope you understand, because yesterday's lecture was very important for understanding the bone healing. Bone healing is little different from the normal soft tissue or skin healing. So there's actually formation of callus and how the callus is formed. All those 5 steps which I told you is very important to remember this one. Okay, that's all. Nothing to worry. I Swal, I Asila. And you can
دكتور
ask me anytime, like one of your student has given me 6 or 7 questions. Inshallah, I will answer it. Or if you just get together 2 or 3 people together, anything, right from information to wound healing to fracture healing, you can ask me anytime. You people have my, you can take from our Dr. Rami, who has my number, and you can ask anything. Dr. Rami, ay swalat wala shay?
دكتور
Yeah.
can you repeat the slide 21 the systemic hormones?
Okay, right. Okay. Is it this one?
Yes.
Okay, right. Now just remember one thing, very important thing I just want to tell you. Now what is PTH and what is calcitonin and what does vitamin D do? Now I'll tell you very, very clearly. Now PTH become active when the serum calcium is decreased. Okay, it will come up and increase the serum calcium by bone resorption. You know it, bone resorption, I told you, it will activate the what do you call the osteoclast, and you know the function will be there and the calcium become normal. What is calcitonin? Calcitonin is secreted by the parafollicular cells in the thyroid gland, and it will decrease the bone resorption by increasing the you know, when there is increase in calcium, it will cause decrease in the calcium channel, because if this calcitonin is not decreased, the increased calcium will go on increasing. So it is opposite to the PTH. Now what is vitamin D doing over here? It will cause increase in absorption of calcium from the intestine. Now these are 3 things which are very helpful in the what do you call it, in the uh, bone formation. Now apart from this, we have steroids, we have growth hormones and thyroid hormones. If these become increased, the fracture healing will decrease. As I told you just now, calcitonin, insulin, and anabolic steroid will increase the rate of fracture healing, because calcitonin will have a capacity for decreasing bone resorption. When you decrease the bone resorption, the fracture healing will of course increase, like the same thing. And again, when you go to little down there, when you have diabetes, diabetes will cause hyperglycemia, and there's a lot of glucose in the blood vessels, and that blood glucose causing will hamper the inflammatory cells to go to the bone area. Okay, because the capillaries become shrunken, all those area will decrease the fracture healing. And hypervitaminosis D is very dangerous, and this will not cause absorption of the calcium in the intestine. This will also impair the fracture healing. And rickets, as you know, the vitamin D problem will also cause fracture healing problems. Now these 3 things they usually ask in the examination of this one, so it will come like that. Now nicotine is present in the dukhan, yani your cigarette smoking. It will inhibit the fracture healing. Now they can ask you, what do they do? The angiogenesis, vascularization will not develop due to nicotine. Nicotine has a problem which has lot of toxic substances which will hamper the angiogenesis. You remember yesterday that doctor might have taught you that in the proliferative phase there is epithelialization. I told you today, fibroplasia and angiogenesis. So nicotine will actually decrease. So this is the basic hormone mechanism of dealt with the fracture healing. It's very important. Okay. Actually, I wanted for more understanding of the hormones affecting not only the bone and other soft tissues. We need actually half an hour to talk on each and every hormone slowly, yani. It will take a lot of time. But usually, you should remember the calcitonin, very important, and PTH important. Okay, corticosteroid growth hormone will always hamper it. That's okay. Okay. Anything next?
Doctor?
Yes.
Can you hear me?
Yeah, I can hear you. Yeah, you be a little louder. Sure. Irfa sauda gallai khali.
We know that there's no scars in bone healing, right?
Yes, you're right.
Is there a way for a physician to know that the bone has been fractured without asking the patient? By just looking at the bone?
Now, what's your question? The second part again, you told that there is no, what do you call it, scar formation in the bone. That I understood. What is the second part?
Is there a way for a physician to know that this bone has been fractured without asking a patient? Like without asking the history of a patient? Can he know this bone has been fractured before? Is there a way? Know that?
No. Can you put the question more properly? You have to ask the patient regarding what, Yane? Can you tell me again the question? There is no scar formation in bone. The callus, the soft callus, the hard callus, and totally remodeling occurs in the form of a laminar bone in a long shaft. So what is the question properly? Yes, doctor?
So okay, the thing is, because my internet as well is not that good. We know when we see a scar in on the skin, we know that
Yes.
okay, this person had been injured before.
Yes. Okay.
In the bone, we don't have scar.
Yes.
Way to know.
Yeah, you should have a
is there a way
history.
to know that?
Yeah, you should have a history. You should have a history. Usually the patient will give a history. For example, for my son, when he was like, he was, I think, 3 years, he fell down from a long height and he had a humerus totally broken, comminuted fracture. And he was so young. Then we went and did the approximation by orthopedic surgeon, and he even doesn't have a scar on the skin. Mashallah. So then if something is happening to him in future, he should give a history to the doctor who's treating him. Without a history, you'll not able to know that there was a fracture before. Like as you told, in a skin wound, you'll have a scar such that you can easily make out. That's the answer.
Thank you, doctor.
Welcome. Anything more? Now, my dear students, please try to buy that Robbins, basic Robbins, not the big one, and try to read each and every word of the first 5 or 6 chapters. Is very important for. I always tell Dr. Yasser Hassan, everybody, that the general pathology is very important. Now, if you have any question right from the cell injury to the first 5 or 6 chapters, ask me anything, anytime. Read it 4 or 5 times in the holiday, coming holiday. All those 5 chapters or 6 chapters in the first 5 or 6 chapters in that book, and understand each and every word. أنا يبغى أن تعرف تفهم الشيء كله اصطلاحات. إذا كان ما يعرف الواحد اصطلاح مشاكل جدا يعني. You will not understand your medicine, surgery, or anything, any problem in the this thing. So be careful, okay?
Doctor,
Yes.
will the cast delay the healing?
No, why you put the cast is because of approximation of the two wounds, two ends, which has to be approximated such that the healing formation of callus occurs quickly. Now, what will happen in cast if the cast is not properly put, or the cast is not the bone fragments are not united properly? Now, if you increase the cast time, then the healing will be in the form of malunion. That is important. If the cast is not now, if the cast is also increased, your question, yes, it will cause disuse atrophy of the muscles around that one. It's again a big problem. You got to go for the exercise like that. So casts have different problem. Improper cast, proper cast for a long time. All these things will, even though they cause fracture healing properly, but there'll be malunion or soft tissue problems, all such things to occur. You will see this in the hospital, and you can ask them, and they will show you a lot of X-rays of the non-union and malunion and cast problems. Yes. Any other question? We have some more time. Any questions from wound healing yesterday, which you people have taken? Anything you can ask me, because I just want to be very basic. Yani, I don't want to go into details. لازم يعرف الأساسي يعني fundamentals. If there is anything regarding regeneration, repair, or something like epitheliation, repair formation, angiogenesis, fibroplasia, also I can tell you. I swallow fracture healing, no problem. I think you can prepare now for your next lecture. 4 minutes are remaining. Rami, Jazakumullah khair. So nice of you. So this new PowerPoint which I gave to Rami, just read that only. The old one, remove it. That was not some non-useful slides were there. So now the new one is only 43 slides something. You can use that. Okay. Thank you. So can I leave Rami now?